My goal with today's talk is to go over some fundamentals of genetics. I'm guessing a lot of you have heard some of the terms that I'll bring up, like autosomal recessive inheritance and carrier screening and so on, but I just wanted to go over these things and make sure there's time to answer any questions you might have. Some of the terms are kind of complicated, so, and I also wanted to go over some more recent data on screening for SLO. The first study I wanted to talk about, I'm not sure if you guys talked about this in recent conferences, but in 2017, one of the largest studies was done to see what the carrier rate is in different ethnicities. And this was one of the biggest studies that told us a couple of interesting things. First of all, the SLO gene is more common than we knew in different ethnicities. It was thought for a while that the carrier rate for SLO is about 1 in 40, depending on the ethnic background. But this study showed us a lot of things that we didn't know. These families in this study were tested as part of a routine carrier screening program. And I will go into this, what this means in more detail later. But the people that were tested had no family history of SLO, like most people don't. And so what they were studying is how many would be identified, and people in the population would be identified as a carrier. And the bottom line is about 1 in 40 people carries an SLO gene. So anybody out on the street of Northern European ancestry would be a carrier. Although what this study showed us is that it's actually seen in other ethnicities as well. It's most common in Ashkenazi Jewish people and Northern Europeans, but it's also been seen now in African Americans and Hispanic people, Southern Europeans. And so this was a bit of a surprise to people because it was thought that most of the time being a carrier was more common if you were Northern European. Had Northern European ancestry, sorry. So I don't want to go into too much detail about this because you guys have heard a lot about this today, but just switching gears a bit, the Dhcr7 gene is the gene that as you know, causes SLO when there's a variant in the gene, and this gene codes for the enzyme, the 7-DHC reductase. Essentially what happens is that cholesterol is made in a step-by-step process, and that last step, it's like an assembly line, that last step in the process is done by the 7-DHC reductase. It's an enzyme, a protein. Oops, excuse me. Whenever a gene has a variant in it that causes the code not to code for the protein properly, that protein may, as the physicians earlier said, it doesn't do its job properly. The protein needs to finish that last step in making a mature cholesterol molecule. And what happens is like an assembly line. That last step doesn't get done. That product at that last step starts to build up, and the mature cholesterol molecule isn't made. And you've all heard, too, that this is a recessive condition. What that means is that both parents have to be carriers before they have a chance of having an affected child. So if you remember from high school biology, this is a picture of a karyotype. The one on the left is from a male, and the one on the right is from a female. And what this is a picture of all of our genes. We have about 20,000 genes. And each chromosome has a few thousand genes on it. And actually, if we were to pluck a cell from your body right now, the DNA material would look more like a plate of spaghetti. But when cells are dividing, they wind themselves up very tightly, the chromosomes do, and it's almost like a slinky. You move the slinky together, and it's really wound up tightly. That's what this is, a picture of the chromosomes wound up tightly. And you can see there are 23 pairs. One from each pair comes from the mom, and one from each pair comes from the dad. And the SLO gene is seen, as you can see here, is on chromosome 11. The green and the blue represent the chromosome that carries the gene with the variant in it that has the, I like to think of variants as typos in a recipe, because when you have a recipe with a typo, the product you're making may not turn out so well. So when you have a man who carries a variant, he's a carrier, the green, and a woman who carries the SLO gene, the blue, the reason it's a 1 in 4 chance to have a child with SLO in each pregnancy is there are only 4 possibilities when you're passing on your genetic material. The man could pass on either the green or the black, and likewise the woman could pass on either the blue or the black. In this case, oops, sorry, this pointer's not working. So it's a flip of the coin each time you get pregnant. When sperm is made, there are 23 chromosomes in the sperm, and when a woman makes an egg, there are 23 chromosomes in the egg. And it's a flip of the coin each time the sperm or the egg is created, whether it gets the black or the green, or the blue or the green. And so there are 4 possibilities when you have 2 parents that come together to have an affected child, because it could be a combination of the blue and the green, and that would be an affected child, or it could be the green and the black from the mom, or the blue and the black from the dad, that would be a carrier, or it could be 2 blacks, and that would be an unaffected child. So that's how the genetics works. And a lot of time people get confused about whether they're unaffected children or carriers, and you hear that there's a 2/3 chance that the unaffected child could be a carrier, and the reason that is you already know that the child is unaffected, so you only have 3 of the 4 possibilities left. But so the child is either a carrier or unaffected, so there's a 2/3 chance that they're a carrier at that point. So again, 1 in 4 chance with each pregnancy. It doesn't, it can be, the probabilities can be a little bit confusing, because it doesn't, if you've had 1 child, it's not less of a chance in the next pregnancy. It's always just a 1 in 4 chance in each pregnancy. So I threw this slide in because I wanted to give you an idea of what your reports say. When you see a genetic report, there's a lot of lab mumbo-jumbo on there, and it's pretty hard to decipher if you're not sure what they're trying to say here. So the C dot and those numbers, the 964, that describes the location in the gene where the variant is that is causing the gene not to work properly. The code is no longer correct. This is where in the gene the problem occurs, and that's always referring to the DNA when you see the C dot. The IVS8-1G to C and the other, the W151, this is all code for telling you how it affects the protein. So what's interesting about this kind of information is that sometimes the location of the variant in the gene can tell you how severe it is. So if you think about a recipe again, sometimes a typo in a recipe can be pretty serious. So you can, for instance, if you're making bread and you have 1 teaspoon of salt and that gets changed to 10, the bread you're making, it's a big impact on what you're making. Genes work exactly the same way. If you have a change in the gene that is serious enough, the protein it's coding for may not work at all, or it may work in minimal amount, or its function is impaired somehow. And so this information in the genetic report can actually be helpful. It's not always a strong correlation of whether the typo is serious or not, but I've heard some of the parents talking about how they have a mild mutation or a severe one, and that can actually give you, your team, especially if you're seeing a team like you would at Dr. Porter's lab, they know a lot about these variants. They can tell, excuse me, I got allergies. They can tell you whether or not, thank you. It's my hotel room always makes me allergic. So if you're seeing a team that's knowledgeable about the specific variants in the gene, and the effect it has on the protein that can give you important information about your child. And sometimes there's not always a strong correlation, but sometimes they know how well the gene is functioning or the protein is functioning based on this information. The top C.964, that particular variant is responsible for about 75% of the carriers that were seen in that study I referenced earlier. And the next two are the second and third most common. And the top one is seen most commonly in Northern Europeans. So the next part of the talk, I wanted to review testing and screening options for SLO. There are a lot of changes. Oh, and by the way, that picture, I took it myself. It's not from Google. No, but I walked past that and I just loved it. But the funny thing about this picture is that, unfortunately, you can't see it too well in this slide, but my 13-year-old was more impressed by the amount of drool that was on the door. So going over testing and screening options, a lot has changed in the past few years. And what my goal today is to update you on what's available. Whether or not people would actually want to use these technologies is a personal decision. My goal today is just to let you know what's available and dispel some of the myths, and also just, I think, better information leads to better decisions. So, so we're going for, and many of you have probably already heard of these things. There are standard prenatal testing and screening options available. A CVS, that stands for Chorionic Villi sampling, and amniocentesis are two ways to test a pregnancy, and they're considered diagnostic. Compared to the two lower ones in the blue, quad, it's also called triple screen. Quad screening and ultrasound are screening tests. They are not diagnostic. So I'm going to go over each of these, but it is important to understand the difference between a screening test and a diagnostic test, because well, there's benefits to both, and we'll go over that. So the first one, the CVS chorionic villi sampling, is testing a pregnancy around 10 to 12 weeks in the pregnancy, and it's a matter of taking a little bit of placental tissue and going directly to do the lab that does it is Kennedy Krieger, and they are directly looking for the level of 7-DHC in the placental tissue. And it's very accurate. It used to be that CVS was thought to have a risk for miscarriage that is high. It's actually about 1 in 450 now. That's what the American College of Obstetrics and Gynecology are quoting. And so it's not, used to be about 1 in 100, but now that new number they're quoting is about 1 in 450. So there is a risk with it. And some people opt not to do that because of that risk. But the amniocentesis is another testing option that is considered diagnostic, and again, they're going directly to the fluid to measure the level of the 7-DHC. I have gene up there as well, because when both of the parents' variants are known, you can also go to the gene and look for those variants. But SLO is one of the few conditions where it's actually better to test for the 7-DHC rather than do the genetic testing, because it's faster, quicker, and just as accurate. So, but the amniocentesis has a miscarriage risk of about 1 in 900. So that's not as bad as it. Yeah, it's gone down. That risk has gone down quite a bit. Both of these tests have been around for decades, and but some people have concerns about putting their pregnancy at risk, so it's not an option for them. The quad screen is just a maternal serum test. They're taking blood from mom, and they're looking for markers in the serum, and it's usually done around 16 weeks of pregnancy. And the quad screen has 4 markers that they're looking for, and when a pregnancy is affected by SLOS, the markers can be small, particularly one called unconjugated estriol. It can be very, very low. So this can be a test also available to people, but it is not diagnostic. So the problem with this is if it comes back and there's a concern, sometimes they want to confirm it with a CVS or amnio. In this case, it would be an amnio. And then another screening test is an ultrasound. Again, it's not diagnostic. There are many signs sometimes that can be seen during a pregnancy with the ultrasound, but there are also times when the baby is affected with SLO and you don't see any of those signs. So, and it also requires follow-up. So I wanted to spend more time actually talking about maternal urine screening. So this is a test where a sample of the maternal urine is taken sometime between 14 and 22 weeks gestation. And there's been some talk about this test, and Kate was asking me, do you know about this test? Have you seen it? And I didn't know anything about it. The reason is that it used to be available. Quest Diagnostics was a lab that was offering it, but they ended up canceling it a couple of years ago because they just weren't selling enough tests apparently. So I started to do a little research, and the guy who invented the technology behind this, not the technology, but the test itself, he's still available. He lives in the West Coast, and he told me that the test is still being done in the UK, and that people in this country could have access to it, but they would consider it research, and it would be it's a bit of a logistic problem, but he said women could send a sample there and have this test performed in the UK. It's a screen. He actually, you don't think it's diagnostic? Okay, no, I trust you. So he said it was valid. I did speak with Kennedy Krieger, and they said that they had validated it, but still as a screening test. Yeah, okay. But so for people who are concerned about the invasive diagnostic procedures, this is available, and it has not been done from the US though, since it became. So the last thing I wanted to go over today, which is something that has also been around for a while, but a lot of people don't know about it, is what's called pre-implantation genetic testing. This is what someone would consider doing if they wanted to have screen their embryo before they would get testing done on embryos and implant embryos that are not affected by SLO. And this is the asterisk up there, diagnostic, as long as the lab has enough information to build up a test that they consider complete and accurate. So the process involves it's in vitro fertilization, taking eggs and sperm, fertilizing the egg with the sperm and allowing the embryo to grow until for about 5 days or so, a little bit over. And then at a certain point, the embryo divides, and there are cells that are destined to become the placenta and cells that are the embryo. And the lab at that point is able, with a laser biopsy, to take out cells that are part of the placenta, so they no longer are biopsying the embryo, it's the placenta at this point. And if they were able to build up the test and by that I mean they have parental samples, they have either an affected child, or they were able to get the grandparents' samples, they, with a high degree of accuracy, can determine which embryos are affected and which aren't, and then they implant the embryos that are either healthy or carriers. So it sounds a little bit like sci-fi. It's actually been around for quite a few years now, but there are a lot of issues with it because insurance often will not pay for it, and it can be quite costly. I said, what's the total cost? And she said, well, including all the IVF cycles, it's about $20,000 to $30,000. So I said, how are people affording this? You know, that's a lot of money. And she said, well, you know, it's one of those things where they ask the grandparents to help, or they save up or, take out a second mortgage, but they're doing quite a lot of these for a variety of genetic conditions. In theory, it can be done for any genetic condition where the gene is known and they know the variants in it. But it's only done in a few centers around the country, and it's really important that you go to a center that knows what they're doing and has a lot of experience with testing genetics, because not all IVF centers are able to do this. But if you want more information, there's a brand new website up called sharinghealthygenes.com. And they have, they might even have a blog up that went up recently that's specific to SLO. I know that they were planning on doing that, but it will give you an idea of what the process is and the reasons you may want to consider it. So that is that. I wanted to just review what prenatal testing options are available and leave time for questions. And I would love to hear what your experience is with this test, because this was just all through an email and a phone call that I had. So, yeah.
But are you done, Karen?
Yeah, no, I'm done. Yep, that was it.
So a couple of thoughts of prenatal testing for the families I've cared for over these 25 years, whatever. So I had one family that decided to go the pre-implantation genetic route, and that is because they had 2 affected children. The older child wasn't diagnosed until they had their 2nd affected child, which was very hard. That always makes me sad when the diagnosis in the older child just took a long time to be made, and then the family had a 2nd affected child. And then they had prenatal testing with CVS for 3 following pregnancies that were all affected. So 5 pregnancies, all affected. They had medical terminations of pregnancy 3, 4, 5, but they were still very, very determined to have a healthy child. And this family decided to go the route of in vitro fertilization, which, if you don't know what that involves, you treat the mother with hormones. It's fairly uncomfortable because it involves big shots in your tush to make you ovulate and have many, many more eggs than you would typically release. And then you have a surgical procedure to extract those eggs, and they're frozen. And then the male donates sperm, and then they mix the eggs and the sperm together and make embryos. And then they look to find the number of embryos that look the healthiest and look like they're growing the best and the most viable embryos. And then from that, you can get it's called a blastocyst, about an 8-cell stage, and you can, with this teeny little pipette, take out just one of those 8 cells in your very, very early embryo and test the DNA in that. And if that is normal DNA and unaffected, you can implant that into the mother. The IVF procedure itself for women who are going through that process for infertility, depending on where you live, costs $20,000 to $25,000 just for the IVF, in vitro fertilization. And then some insurances cover it, but many do not. And then the pre-implantation genetic testing on top of that, it costs another number of thousands of dollars depending on what specific disease you're testing for and so on. Some people do pre-implantation genetic testing just to look for chromosomal abnormalities, which is very easy and cheap. But if you're doing something much more specific like this, where there are only certain labs doing it, it's more expensive and more difficult. In terms of the other options, I think one of the reasons that they stopped doing the urine test in this country is that it was a screen, and women still had to go on and have the other test that you mentioned, and then you were further along in your pregnancy when you then had to go through those other procedures. So most women elected to not do that. And the one other thing I wanted to mention about CVS has been a very, very helpful option for women because you can do it when you're still in your first trimester. So most women in your first trimester, nobody else even knows you're pregnant. So if you have to make a difficult or painful decision about an affected pregnancy, it's shared between you and your partner, and the whole world doesn't have to know what you've gone through and decided. So that's why a lot of women elect CVS. When CVS first came around and people started to do it, there were increased reports of limb anomalies in women who had CVS at 10 or 11 weeks gestation. So now many centers wait until you're past that, and more like 12 weeks to do the CVS to make it be a more safe procedure and reduce the risk of limb anomalies in the fetus. What you're doing, you're using an ultrasound to guide your needle, and you're going in where the placenta is just starting to attach to the uterus and taking cells from there. They're very rapidly dividing and growing cells, and so your results from CVS come back fairly quickly, which is another benefit to CVS over amnio, which is done in the beginning of the second trimester. So by then, many people know you're pregnant. You're 15 weeks or so, people know you're pregnant, and then you have to wait, for in this case, it's a test in the fluid itself, so you don't have to wait as long as growing cells from the amnio and testing for the gene, which is why it's faster to get your chemical results back. So if you have a child with SLO and your risk is 25% in each pregnancy subsequently, one of these procedures, prenatal procedures, should be offered to you. And then it's your decision whether you want to do it or not. No geneticist will ever tell you got to do this. The geneticists give you information, and then based on your own feelings and family sense and your religious beliefs and all of those things go into what you decide to do with testing and what you decide to do with the information once you get the testing back, right?
Yeah, thank you for that. Yeah, I'm a cancer genetic counselor, and I don't have experience with the urine screening at all. And I do know that some people are really worried about putting their pregnancy at risk, even though the risks are very, very tiny with CVS and amnio. So thank you for that, because you've never considered this urine screening, even though when Quest was offering it, you did not consider it to be diagnostic?
Well, I remember being at genetics meetings and hearing all about it.
Yeah.
But people's thoughts were, if you're going to do a definitive diagnostic test anyway,
Then do it with the CVS or the amnio?
Yeah.
Yeah, that's what my understanding. Yeah, I think people are interested in it though anyway, so. All right, well, thank you for that. So the last thing I wanted to talk about is something that some of you have probably heard about, carrier screening. I mentioned it earlier, and it's something that is probably fairly new to a lot of your OB-GYNs or your healthcare providers. Carrier screening now is very different than what it used to be even a few years ago. The technology has changed drastically in the last about 2012. We're now doing genetic testing by a method called next generation sequencing. And what that means is that instead of looking at one gene at a time or a few genes at a time, labs can very efficiently, for a very low cost, look at a lot of genes at once and to see if you're a carrier for any number of recessive conditions. And just as an example, there's a lab that is now testing for 300 conditions at one time, and they just announced a couple of weeks ago that they're going to have a model where it's more of a direct-to-consumer approach, which isn't ideal. I think you should go and see someone in person if you can, because you need to know what you're doing. But I'm bringing this up today because you're going to be seeing this advertised. 23andMe has done a great job of making the world of genetic testing seem easily accessible. And what it is it's a kit. This little plastic tube is called a saliva kit, and they will ship a kit directly to your house, and for $250 they'll have one of their clinicians order the test, and the SLO gene is on that test. And it's fantastic that there are fewer barriers to genetic testing, but it can also be quite shocking to do this test and find out you're a carrier for SLO, and maybe another gene, cystic fibrosis, for instance, is common in Caucasians. Sickle cell anemia is common in other populations. There's quite a few conditions that they look for with this test. So it's good to meet with somebody, know what you're getting into, and decide if you really want to do it. So if you do go ahead with it and you come back and you're identified as a carrier for, say, SLO or some other condition, then what they say to do is to test the partner. This particular lab will test partners for $100. So it's still, yeah. Mm-hmm. No, I'll get to that. No, yeah, thank you for bringing that up. And the reason I have that last bullet point, not all tests are equal, is because 23andMe is a little bit misleading, and they, so this lab is called Invitae, I-N-V-I-T-A-E, and they're the first lab, to my knowledge, to offer this test with this new direct-to-consumer model. They're actually having a clinician order it, so, and they do have a team of genetic counselors and staff that will help you if it were to come back positive for anything, but they ship a kit to you directly, just like 23andMe does. So it's pretty interesting that you can get your own clinician to order it, yeah. Or if you don't have a clinician that can do that. Now, when is this helpful? It's helpful for family members. If you have siblings or cousins, aunts and uncles, anybody who wants to know their carrier status, it can be helpful. And it can also be great that the fact that there are so few barriers to getting this information can be very helpful, because I think it was Dr. Porter who said, you know, you have to fight your insurance company sometimes. They're not going to do carrier screening. I-N-V-I-T-A-E. And I don't want to promote just one lab. I use this as an example because they just announced this a couple of weeks ago. There are other labs that are doing carrier screening. One's called Counsel, C-O-U-N-S-Y-L. They have a very good panel, and they also are really experienced, more experienced, in fact, than Invitae is. But, sure. They'll ship it internationally. Mm-hmm. Well, okay.
This one got switched off and. Hello. That one.
It's okay. Yeah. Sorry, my question was just in regards of you've answered, but just for the purpose, the shipping it will do internationally, and it was, do you need to get a doctor or somebody to order for you? As I said, over in where I live in Dublin, Ireland, there is no testing facility in Ireland for Smith-Lemli-Opitz. It has to be done in Great Ormond Street in England. Now I'm sure it's elsewhere, but that's where our children's bloods were sent. I have two children who don't have Smith-Lemli-Opitz, but I would like to know if they're carriers, and then therefore, you know, I was only out with a close family last week, and as we were talking, you're realising, well, you know, if I carry the gene, siblings belonging to me, therefore siblings belonging to my mother or father, whoever I have had the gene passed on for. So this is brilliant for me to be able to bring home that this is a possibility, but rather than having to go through the whole doctor system, whatever, is it available that you can just call up and say, you know, can you be tested for that? And just also a question on that as well, you said with the cystic fibrosis, Ireland, I think, has the highest rate of cystic fibrosis in Europe for carriers and for a thing. And my husband was adopted, and unfortunately he passed away 6 years ago. But just before that, we found out that his biological family mainly are carriers for the genetic cystic fibrosis. So now I'm on the verge. I need answers for Smith-Lemli-Opitz and cystic fibrosis for my bias. So.
Yeah, that's, so your first question, do you need a clinician in Ireland? I'm actually not sure about that. I know in this country, they have the staff to order the panel for anybody who wants it. I don't know if international laws, I don't know, do you know? Yeah. So if you were to be, I think what the easy way to get it done though is go to your GP, say, I want you to order this test. You can ask the lab to ship you the kit. They'll ship it over to you, bring the kit in with you, explain to your doctor what you're doing. It's carrier screening, and there will be a long list of genes on the panel. And then I would guess that they would be willing to do it because you're paying out of pocket.
Yes,
No.
Is a very good website.
Mm-hmm.
And you can go on the website, your doctor can, and download the ordering.
yeah, because this is huge, I think, is really...
Yeah, it's a really...
It's more available and therefore more accessible for people, I think.
Yes, that's what they're...
As opposed to go to specialist doctors. To be able to go to your own GP, to be able to go to your own GP and get a kit. Now, I know it's $250, but you'd pay that for, you know, peace of mind. Well, I certainly would, you know, that way. And then the extended family. I just think this is brilliant, like, to be able to do that.
I just, so you know, I tested my own daughter, who's not married yet, but I believe that it's really important information to have. The chances are that, you know, she popped up as a carrier for one condition. And by the way, most of us carry at least one condition. SLO, CF, or any number. There are, I think, the study that I quoted earlier said that 5% of the people carried 2 conditions. I tested a young lady a few weeks ago that I saw because she has a brother who has a neurological condition. They didn't know what it was, but she just wanted to get carrier screening. She came back as a carrier for 4 conditions, 4 serious ones. It wasn't, you know, these were conditions that she needed to know about. So panel testing is fantastic. It does it all at once.
Thank you.
Wait, your second question, did I answer that? Okay. Okay. Any other questions?
I'm sorry, I didn't want to interrupt you, Karen. Did you have more slides you were going to
No.
Okay. I wanted to say just one thing in response to one of the moms who was talking about me earlier, testing for SLO itself. The test needs to be done at a special lab. Your doctor just can't send a cholesterol test to your lab in someplace, New Jersey, right? It has to be done in a lab where they can differentiate the cholesterol from the 7-dehydrocholesterol. Okay? So I've been asking a couple of people, well, do you know what your kid's cholesterol level is? And it was done in just the regular hospital lab, and it was 100. That's probably not really true. Probably the true cholesterol is less than that, and that 100 was a mix of 7 and 8-dehydrocholesterol plus cholesterol. So it's important that whoever you're seeing who's trying to make a diagnosis of SLO, and that is in fact how a lot of patients were missed or diagnosed later, is that people didn't realize that the test for SLO, the blood test, has to be done in a very specific